Now, for the next session, as you can probably see, I'm joined on stage by UICC CEO Dr. Cary Adams. Cary, it's great to see you again. You're going to be moderating a discussion between three UICC board members who are coming to share their regional perspectives on driving innovation to advance cancer control equitably. It was a great day yesterday.
It was indeed.
And
tremendous.
We've got lots planned for today as well. So
You're going to be very busy.
No, probably not as busy as yesterday, but certainly it will be a busy one. Well, I hand over to you now, and good luck with this next session.
Thank you very much, Hannah. I now have the pleasure to introduce a second of two panel discussions featuring members of the UIC Board of Directors. Yesterday, I had the pleasure of the company of board members from Sweden, the USA and Lebanon. But today, I have the pleasure of introducing board members from Mexico, India and Nigeria. In each of these two sessions, we have discussed innovation and equity from the perspective of each board member's region. UIC has more than 1,200 members in 173 countries, and in preparation for these two sessions, our board members have canvassed opinion on the critical issues our members face in their part of the world. Today, we'll focus on Africa, Asia Pacific and Latin America. And for those of you who wish to hear the views from Europe, North America and the Middle East, please see the recording which is available on the Summit platform. So let me now welcome our three panellists. CS Pramesh, Director, Tata Memorial Hospital in India; Zainab Shinkafi-Bagudu, Chief Executive Officer of Medicaid Cancer Foundation in Nigeria, and also the First Lady of the Kebbi State; and Kenji Lopez, the President of Cancer Warriors of Mexico. Welcome to my board members. It's nice to see you. I'll start by giving the floor to CS Pramesh, live from India, who will give an Asia-Pacific view on the issue of innovation and equity in cancer control. So, over to you, Pramesh.
And without the video,
Are you there, Pramesh?
Yes. Can you hear me now?
We can indeed.
Great. Thank you, Cary. It's been a wonderful World Cancer Leader Summit so far, and I'm thankful that you chose me to speak about this very important concept of digital health. So conventionally, we've looked at digital health as telemedicine and pathology. And for those of you who remember, this was just a decade back, and all we could think of about transforming lives across miles and kilometers, as your situation might be, was these two aspects, telemedicine and pathology. But we made phenomenal progress over the last few years, and we have grown much beyond this now. We are thinking of artificial intelligence, natural language processing, pattern recognition, and it's sobering to know that if you have a Google account, whether it's Gmail, YouTube, whatever it might be, 98% of your life is fairly visible to the rest of the world. So digital health has penetrated every aspect of cancer care, the entire spectrum from health promotion, prevention, screening, early detection, diagnosis, treatment, supportive care, and survivorship. Things that we struggle with on a daily basis as we run cancer centers in different parts of the world. And most importantly, when all of us are striving for universal healthcare, and I don't think anything has exemplified this more than the COVID-19 pandemic that we've had over the last year and a half, or a bit more for some regions of the world, that digital health has the potential to completely transform the way we treat health and healthcare. There are several examples. If you look at mHealth and wearable devices, they've completely had primacy in health promotion and in promoting lifestyle modifications. I think all of us who have a Fitbit or any form of wearable device have realized this. We now have digital tools for screening, to the extent that we have the ability to transmit images, as in digital cervicography. So the old excuses of not having enough human resource to interpret smears is no longer applicable thanks to digital cervicography. We also have artificial intelligence tools for diagnosis And pattern recognition has now become mainstream. And we now realize that we are using this very extensively in both radiology as well as pathology. And just as Mr. Rafael mentioned just now, you could have people from different parts of the world actually contributing towards the care of an individual patient millions of, rather thousands of miles away in several regions of the world. We have mHealth tools which track patients from diagnosis to completion of treatment, the entire spectrum, and go on to looking at survivorship and follow-up as well. During the treatment, we have patient-reported outcomes, and we now have evidence to support the fact that monitoring toxicities and response to treatment can be very well done using digital health tools, much better than we can with conventional or traditional tools. Much of these have been shown to improve the patient experience, reduce symptom distress, unplanned hospitalization, and their associated costs, as anyone who lives in a low middle income country would testify to. But most importantly, they've been shown to improve quality of life of patients who access care. There are a few applications where digital health is less recognized. Again, Rafael mentioned about virtual tumor boards. In the National Cancer Grid in India, we've been running virtual tumor boards for the last 4 years now. We've done over 800 virtual tumor boards, which completely democratizes the concept of multidisciplinary approach to cancer care. This is something that's not so well recognized because we typically look at digital health as a treatment option. But what we actually have ended up doing is to look at it as an educational and training opportunity. So the virtual tumor boards that the NCG runs in India is a typical testimony of this. So earlier on, 5 years back, we had very simple patient situations being referred to the virtual tumor board. But the virtual tumor boards that we currently run within the National Cancer Grid of India are some which would challenge the best in the world. So the complexity of the cases have increased, which means that over the period of time, this has not only been a patient care initiative, but also has been an educational training initiative. The last application that I want to mention about is a pilot project which is being done by the Indian government, which is the initiative of a national digital health mission. And what it has as its center is to have a digital health ID which unifies all your patient health records. And this is something that National Cancer Grid worked on over the last couple of years, and which directly went into the National Digital Health Mission. So a few years from now, and given the way the Indian government has functioned over the last few years, I wouldn't be surprised if it's as early as 2 years now. Every individual in India will have a digital health ID, which will link every single bit of their health records into a single unified platform. And the power of this and the data that it generates is phenomenal. At the same time, I would like to add a word of caution. The 2 points that we need to be very conscious of when it comes to digital health is cultural context and clinical validation. Cultural context first, because it's important considering that we are a global village now. Interventions need to be tailored to the cultural context in which they are being implemented. And what works in one region may not necessarily work in another. And we need to make sure that what we are offering to our patients is something that is available to everyone. But most importantly, the technology needs to be validated. Unlike in hardcore technology, where all you need to prove is that a new processor is faster and more agile than the older one, in digital health, we need to prove patient benefit. And we've had innumerable examples where these have failed to live up to their promise. And finally, when it comes to cancer, it comes down to 2 fundamental questions. One, are my patients living longer? And second, are my patients living better? And if digital health solutions don't answer these 2 important questions, I don't think we've answered the question. And I think that as technology adopters, we need to ensure that we ask these hard questions to industry and ensure that they are being answered appropriately. I'll stop with this, and we can probably take more questions during the Q&A session.
Pramesh, that's great. Thank you very much. Perhaps I could ask one quick question as a follow-up before we move on to Zainab. How data from the digital health tools could be used for population-based epidemiology purposes, including registries? I mean, having the data at individual level would be ideal if you're going to have health information at individual level in India. But how will it actually help you think?
That's a terrific question, Cary, and I think it comes to the heart of what we are working with at digital health as a solution to optimize universal healthcare. So the entire concept would fail if we were not able to link it to any kind of registry. And let's take cancer as an exemplar. So if we were able to have a unique ID which links your health records to registries, whether it be cancer or otherwise, or any other health registry, you automatically have this option and the ability to link a longitudinal scale of what the patient is going through. And this is not something that comes easily. And considering that cancer is likely to, about 70% of cancers are likely to be in low and middle income countries over the next couple of decades, this is not something that we can trivialize. So linking digital health ID, health records, birth and death certificates to these IDs would be fundamental to ensure that we have reliable data to what we are trying to do. And cancer registry is an excellent example. We had Dr. Vidapas speaking yesterday about the importance of the IARC cancer registries. We had the IAEA speaking about the importance of getting important data today. And I think linking digital health IDs, health records to outcomes is fundamental to this overall purpose.
Pramesh, thank you very much for that. That was fantastic. Let me give the floor to Zainab for her to give her views from an Africa perspective. Zainab, the floor is yours.
Hi, Cary. Yes, thank you for that digital overview, Pramesh. And indeed, Africa does carry the greatest burden of cancer globally alongside the other low middle income countries. Not just the burden, but also the mortality and the highest mortality and morbidity. With a population of about 1.3 billion, we had last year reported 1.1 million cases of cancer with 700,000 deaths. And of course, the prevalence rate is higher at about 2.1 million. Breast cancer has the highest incidence, followed by cervical and prostate. Coincidentally or strangely, in my country, Nigeria, prostate has now overtaken it. We're not quite sure the reasons for this. It has overtaken cervical, and it's now breast cancer, prostate cancer. Last year, the entire globe witnessed a challenge in the form of the COVID-19 pandemic. And this exposed the weakness in all health systems, not just low middle income countries, but high income countries as well. And it was followed by an unprecedented need for a highly skilled workforce. Alongside that pandemic came another very innovative discovery, which was the COVID-19 vaccine. What the vaccine on its own did was to expose the inequity of the health system that we in these parts are somewhat used to living with. And particularly when it comes to cancer care, the gap between the high income and the low incomes is great because of the reasons that we all know: poor access to treatment, low education, hard to reach areas, insecurity, and of course the financial burden. Most people have to pay out of pocket. Insurance is not the norm, and this makes cancer care an increasing issue. The workforce for healthcare is a big issue for us now, particularly after the COVID pandemic, where we're seeing from the high income countries a deliberate attempt to woo the health workforce to the other countries so that they can improve their own health systems or the gaps that they have been found in their health systems. In Nigeria, we have less than 100 clinical oncologists for a population of 206 million people. So this, at the flight of the health workforce is causing an even greater burden for cancer care. We have been discussing ways in which we can improve on this. And one of them is the digital transformation that Pramesh spoke about. By using that more and engaging in maybe tumor boards across with the countries that have more resources and are able to do it. But technology, ICT, is still a challenge. You can see I cannot speak to you with my video on because it's still quite unstable. So for us to be able to make a difference in our healthcare, we need to look more inwards and look at the homegrown resources, maybe work together with the councils, the registration councils, so that we have collaborations across the countries whereby there's specification of a certain number of years that they need to be served in the country before they move abroad. Health spending is another major issue for us, despite the Abuja Declaration by the African Union over 19 years ago, that at least 15% of our national budget should be dedicated to healthcare. The political will for this is still lacking, and other competing priorities are always being quoted. We have not had more than 8% of the total national budget dedicated to healthcare. Even though if you look at it in the relative figures, it's still 15% would still not even scratch the surface. But for us to be able to get the cooperation, at least there should be that internal political will, and we should reach the figures that we have agreed to. That is the 15%. Of course, medical training and education and things like working together with the more established medical unions will be beneficial. We have a large population of diaspora abroad that are working in healthcare, and to woo them back actively, we have to institute better returns or better conditions of service, social welfare systems, and improve that will help us to improve the patients to doctor ratio. For us in Nigeria, it's about 4 doctors to 10,000 of the population. And we know in the higher income countries like the UK, America, it ranges between 26, 28, Canada, and so on. And so we are still yet to cross the single digits. Agreed that both of them are well below the recommended by the WHO. So I think these are some of the things. It's very difficult to give a complete snapshot of what the situation here is, but the main pressing problems that we're having at the moment, aside from the usual resources and unavailability of equipment, lack of awareness, is the flight of human health care for capital for health. That is what we're facing. There are ways in which we can actively stop this with working together and engaging stakeholders across different platforms. I'll stop here now, Cary.
Zainab, thank you very much for that. We may not be able to see you on the video, but I can assure you, you are in UICC colours in the photo that I'm looking at. So I'm very proud of that. So congratulations. Perhaps I could ask one question before you go. Can you tell us about the gaps in diagnosis and screening in the region? What are the major issues there?
Sure.
Zainab, can you hear me?
Well, we would start from the awareness. Not being aware that you need to be screened is one of the major issues that we have. And then, of course, there are no institutionalized screening systems for most of the cancers, most diseases, actually. By that, I mean, you don't get a call-up letter at a certain age to come and get your breast ultrasound or pap smears, as we do in countries that have a system established. And then, of course, when people don't know, even when it's available at the primary healthcare level, or when they're not educated enough to access those cares, there is a problem. This morning, I got asked a question about HPV screening. It does exist. We have the facilities that do it, but their reagents go out of use and they expire on them because there is no demand for it. So demand generation is poor, and that is a big issue when it comes to diagnosis and screening. And yes, we do have issues with availability of the high-end equipments that are able to work quicker and faster and more accurately now. And as I mentioned, access to these equipments can be far for most people. We have 6 functional radiotherapy centers now. 2 of them are public, the rest of them are private and beyond the reach of most people. However, to get to those 6 involves considerable amounts of travel for most of the cancer patients. So distance in between each center is another problem that we're facing. So these are just some of the things. And of course, by government and private sector working together with the partners like the UICC, we hope that we'll be able to improve this situation in the near future.
Zainab, thank you very much for that. And as you know, the UIC and its members are very supportive of the work that you do and of the challenges that you face in Africa. We'll now go over to Mexico, where Kenji Lopez is waiting for us to share with us a perspective from Latin America. Welcome, Kenji.
Hi, Cary. Greetings to you and to my colleagues Zainab and Pramesh. I'm honored to share this panel with you and would like to congratulate extraordinary and innovative work you have done and to the awesome team at the UICC. We will pass from let's rock it to let's wrap it. Cary, law is a powerful tool that that can guide governments in the path of addressing cancer control. The law can create financing funds, national cancer control programs, regulatory frameworks, and to expand or defend cancer patients' rights. Additionally, it is capable of authorizing or to limit the actions of governments and, of course, to guarantee equity in the access to cancer treatments. However, when the implementation of a law requires economic resources, it is essential to guarantee them. During the last decade, several reforms to the health systems here in Latin America have allowed to increase health coverage and equity in access, thanks to an increase of the GDP on health, passing from 1.4% to almost 3% in some countries. However, these percentages are still very far from what is recommended by the Pan American Health Organization, which is 6% of the GDP. Cancer care public policies are required to guarantee access to quality and effective care, especially for people who experience several social disadvantages during their lives. For them, inequity is a constant, not only in access to health, but also regarding access to education, work, housing, and other human rights. Because indeed, as it is stated in Article 25 of the Universal Declaration of Human Rights, health protection is a human right. I would like to share with you some examples of what we are doing here in the region, Latin America, because we are understanding that the use of law is an effective weapon, an effective mechanism in the field of cancer control. In Peru, 2 months ago was adopted and published the National Cancer Law to guarantee universal coverage of health services for all cancer patients, regardless of the type of cancer diagnosis. We also have the special law for the prevention, control, and attention to cancer in El Salvador, which was approved also during this year, in last March, to establish a normative and operative framework for cancer control in that country. And of course, we have the general law for early detection of childhood cancer here in Mexico, which was adopted last January and has as main objective the early detection of childhood cancer through different mechanisms applied by the public health sector. As we can see, we are conceiving the use of law as an effective form to reduce the burden of cancer in many powerful ways. We have a challenge, yes, the main challenge is to provide economic resources to guarantee the implementation of the respective laws. I would like to conclude this part of my intervention by quoting my colleagues and dearest friends from the Maccabi Center for Law and Cancer. Law has the power to shape norms and behavior of individuals, organizations, and governments. When it comes to health, engaging with law is crucial at all stages. Thank you, Cary.
Kenji, thank you very much. And I think everyone gathers from that you are passionate about the implementation of law as an innovative way of improving cancer control around the world. And you and I share the platform working with Medicaid, which I know we both enjoy doing. Can I ask one follow-up question with regard to international law? How can it be used for national progress in, for example, a critical area risk factor, which is tobacco control? What are your thoughts on that?
Well, this is a quite interesting question, Cary, due to on last Sunday, we commemorate the United Nations Day that marks the 76th anniversary when the UN Charter entered into force. This date is a symbol, a global symbol of hope for global unity and an opportunity to enforce all the common agenda and to reaffirm the objectives and principles of the Charter. I'm talking about this because we have different international law frameworks, such as the World Health Organization, the WHO Framework Convention of Tobacco Control, the FCTC, as an international treaty based on evidence that reaffirms the right of all people to have the highest possible level of health and establish the importance of demand reduction strategies and all the issues related to the supply chain. With this, it is important to emphasize that all the member states parties of the convention, it means the countries that ratified it and all the member states of the UN and the World Health Organization must comply with the convention as an act of prioritizing the health of the population. How we do this? By amending or incorporating national public policies and domestic legislation. In Mexico, for example, we published in 2008 the General Law for Tobacco Control with the objective of protect the health, the rights, and laying the basis of the reduction of tobacco consumption. Additionally, on last year, by presidential decree, it was prohibited the importation of electronic cigarettes in order to protect society in accordance with international commitments and the fundamental right to the health. This is an example of how how from international levels, we should integrate in our own countries the mandates contained in international conventions. Thank you, Cary.
Thank you very much, Kenji. And I think we all agree with you on the follow through on the FCTC and the recommendations and getting countries to put tax on tobacco, et cetera, et cetera. So thank you very much. Now, we've seen some great interaction on the Summit platform during this session, and we'll take some questions from the audience. Let me just have a see. Let's look at how can digital health be transformative for access to care and medicines? Maybe I'll ask Pramesh that. Access to care and medicines, how can it be transformative in terms of digital health? Any views on that, sir?
Thanks, Cary. That's a terrific question. I think it comes to the fundamental aspect of access, which it's a term we use very loosely. But when we looked at the National Cancer Grid in India, we realized that people had to travel thousands of kilometers to be able to access what they considered as quality cancer care. And this is the area where we think digital health can actually play a big role. So I mentioned to you about the impact that the virtual tumor boards had. So what it instantly did was to create virtually a platform that enabled medical oncologists, surgical oncologists, radiation oncologists, pathologists, radiologists, palliative care physicians, supportive care, survivorship, all of them to come onto a single platform virtually, regardless of which time zone they were in, and actually contribute towards an individual patient's care. And this is something that we look at very lightly over the last year and a half, considering that COVID has taken over our lives. But as close as 18 months back, we didn't know that this concept existed. And this is something that we need to leverage very quickly. The second aspect is another initiative, which again, we have a pilot within the National Cancer Grid, which is an online expert opinion service. So all that a patient needs to do from across the world is to upload their reports, their scans, their DICOM images, their pathology images onto a secure web platform, where it's converted into a structured format, which makes it easy for experts from across the world, volunteers who would want to contribute towards global cancer control, to offer opinions, which automatically makes it not a real time, but seriously a sequential multidisciplinary board. And this is a luxury that many of us in apex cancer centers take for granted. But what we need to realize is that this is out of reach for the vast majority, approximately 2/3 of the world's population. And if we are able to implement this well, I think we would have truly democratized cancer care across the globe.
Thank you for that, Pramesh. Kenji, maybe I could follow up on the issue of data and patient data. There's lots of legal aspects to that about sharing data and things like that. What's your experience as a lawyer working in Mexico and the region with regard to the law and data and who owns the data?
Well, this is a big problem, and I'm talking in a global aspects. We are still working on it in our country and countries from Latin America, because we need to respect data and personal information of patients. But from the other side, it is important to have this information in order to have better treatments and better information for doctors, medical, and all health aspects. So it is important to, to walk in the same paths. I mean, in the same path as the treatment, it's important to have the information of patients, but having all the time protection of data and having respect of their patients, Cary. At this point, every country has, is working on their own legislation, but my recommendation is, if I can make it, is that both needs to walk in the same paths. We need this, what the health sector needs to obtain the information, to construct data, as you just mentioned, statistics and stuff. But at the same time, we need to protect the information of patients. One is not more important than the other. What we need is, as just mentioned before, is to amend or incorporate legislation that supply with the needs of the health sector, but at the same time to protect the rights of data in patient sector.
Thank you, Kenji. Perhaps I could just ask a question of Zainab. Zainab, we've had a question come in about palliative care. And you'll be aware that this is something which UIC has championed over many years, about access to opioids and palliative care in regions where treatment and care and late presentation is the norm. What is the situation with regard to Africa, and what are your thoughts about palliative care at the moment?
Yes. Although we have such a high rate of mortality, morbidity, and we really should have a better palliative care system, we do not. That is the truth of the matter. And I know that I speak for most countries across Africa. A lot of our patients, first of all, go to alternative care healers, traditional rulers, religious healers, before we see them in the hospital, so that they're presenting at a very late stage. And what we should be concentrating on is how to improve the quality of their lives and not go through any further difficulties, so to speak. But we do not have the palliative care that they need being offered to them as much as it should be. Yes, there are pockets where you will find morphine and so on, but generally, as a people, it is not well accepted. There's always this belief in that the cure is going to come from doing other things and not just to accept it as a terminal, end of life care is what this patient needs. And I think it's not just from the side of the people as well. The healthcare workers, the doctors, the nurses must also take some responsibility for this. Instead of offering a patient palliative care for what is obviously a hopeless case when we see them, they tend to get offers of, let's try this and try the radiotherapy and try other things before we get to the point, which we can argue about it both sides. But really, there's a lot more that needs to be done when it comes to improving the quality of life of even those that are still fighting the disease and struggling with the pain that it can put them in.
Zainab, I think we can all agree with that. I'm just going to ask a quick question, a quick round robin, no more than 40 seconds at most, if that's okay. So the COVID crisis generated different innovative approaches to patient support. Can you share your perspectives from your own region? Anything sustainable in your region you've seen, Pramesh?
I think there have been several silver linings to the COVID pandemic. I think we've seen the fact that nobody is safe unless everyone is safe. That's a fundamental principle of universal healthcare. And we've seen it driven over and over again with the vaccine inequity that we see here. And I think it's shameful that the world's, especially the high-income countries, consider it appropriate to hoard vaccines when it's getting wasted and when the rest of the world is not getting adequate vaccines of it. So one aspect of it is the equity that comes with healthcare. The other minor points that I would like to emphasize is the fact that virtual learning, virtual treatment has become the norm more than the exception. And I think I would welcome that because it again works towards democratizing healthcare across the world. I'll stop with that.
Thank you very much, Pramesh. Kenji, any innovative practices you've seen through COVID for cancer treatment and care or support that you think could be sustainable?
Yes, Cary, well, considering that law is made by legislators and that they are voted on by us in electoral processes, we launched a digital initiative called El Cáncer en la Agenda, in English, Cancer in the Agenda. 2 months before our last electoral process here in Mexico, we asked candidates for governors, mayors, and legislators positions from all the political parties to sign a public commitment to include actions on cancer control as a priority on their agendas. The response was extraordinary. We obtained more than 300 signatures in 21 states in Mexico. And now we have results. We have elected legislators and we have presented 2 bills to promote, by using law, breast cancer early detection focused on working women. This initiative is applicable to any country that has a democratic election system. And it is important to consider that even though we have different languages, varied cultures, and different origins, our enemy is the same, cancer. But it is only one, this is only one, the cancer. And we have millions of people as allies convinced that if we work together, we can defeat it, Cary.
Thank you very much, Kenji. Zainab, I'm going to leave the last word to you. If it could be short, please, because I've just seen we're nearly running over in time. Anything from you, any inspiration that you've actually got from the COVID times, innovations that you think can make a difference longer term?
The investments that we've seen that it's possible. We always hear there's no funding, but then somehow with the political will and the scare of COVID, a lot of investment came into the healthcare sector and into cancer care in particular through the importation of equipment that can carry out molecular diagnosis. So what we need to do to sustain it and to make it work for us, particularly in eliminating cervical cancer, is to convert these equipments to the diagnosis and screening for HPV and institute national screening programs and vaccination programs that will work and help us get to the elimination point.
Zainab, that's a great way to conclude today. Inspiration as usual that we can eliminate a cancer and maybe there's going to be more funds available. So thank you very much. Thank you very much to Pramesh, Zainab and Kenji for such an engaging panel. That concludes the second session featuring UIC board members discussing the summit theme through the lens of different regions of the world. And I hand back to Hannah to continue the summit programme. Over to you, Hannah.
Thank you very much, Cary, and a fascinating discussion there.